Wow. Okay. All right. So chapter 16. I'm gonna go off of this, guys, because my technical difficulties here. So pain management. We're gonna be discussing pain management. What type of medications we give. What medications are we gonna be cautious of giving the patients because it might depress something. We'll talk about respirations in a bit. Comfort, rest, and sleep. Okay. So by definition, the meaning of comfort, one of the greatest challenges for the nurses is to provide comfort to the patient. Now, again, why is this so crucial and why is it so difficult for us to provide comfort for the patient?
Because we're not feeling what they're feeling.
Exactly. We don't know exactly what they're feeling like. A lot of the times they're in pain and they don't tell us. They don't verbalize it. So one of the most difficult things for us to do is to provide comfort for the patient. Please write that down, highlight it, do something with it. Okay. We give comfort in order to give strength and hope, to cheer and ease the grief of a trouble of another one. Promoting physical and psychological comfort is a vital part of the role of a nurse. Now, there's two different aspects of pain or of comfort that we deal with: the physical and the psychological. When we talk about physical, what am I referring to?
Pain.
Okay, pain meds, right? But comfort. Sometimes, you guys remember when you were doing first term, they told you to have no creases on the linen.
Yeah.
Okay, the older adult, they have very thin, frail skin, so even a little crease on the sheet is going to actually prove to be bothersome. So we want to make them as comfortable as possible. We want to make sure that we brush their teeth. We want to make sure that we bathe them daily or a few times a week as you get older. Yeah, a lot of the times, you guys know, remember we did a little experiment a few weeks back, the whole positive thinking, what it does to your body, negative thinking, what it does to your body? The same thing applies here. Okay, if the patient is in a positive psychological state, they're going to be more pleasant, easier to combat the pain. If they're going to be very upset, okay, and they feel like they have no hope, they're going to feel the other way. Okay, you guys know that we can control pain also by talking to them, or sometimes by something called guided imagery. You guys know what guided is? Like a distraction. I showed you guys the movie Mar Adentro.
Mm-hmm.
Okay, remember when he's discussing he says he goes and visits the beach every day. He goes out and he flies out to the beach even though he's a quadriplegic. That's an example of guided imagery. Mind you, he's doing it himself, but a lot of times us nurses, we have to do that. And if the pain is in a lot of pain, and you know when the medications are ordered, you can only give them sometimes like every 3 hours. So what if like it's been only 2 hours since you gave the medication, the patient's still in pain, and you can't get a hold of the doctor just yet. You already tried, but the patient's in pain. What do? Yeah, you try to talk to them. You try to do something else. And we're going to start talking about the gate theory in a little bit, which is when you provide physical stimulation to the patient to kind of block the pain receptors and then have them focus on that. I'm sorry, what?
Like a back rub?
Yeah, like a back rub or anything like that. All right, the meaning of comfort. The lack of comfort can be a result of many factors and can take many forms, including, of course, anxiety. Anxiety is going to be the biggest one, folks, because if a patient's in a lot of pain and none of the medications that you're giving them is working, they're going to be so anxious, they're going to start breathing faster. And what happens when you start breathing faster? What are you blowing off? CO2. Okay, and you guys ever hyperventilated and gotten really dizzy? Okay. Was it this class?
Yes.
Okay, well, I think it was this class that a patient, that one of you guys hyperventilated, right?
No. You hyperventilated.
Oh, but I tried to prove a point. I wasn't freaking out. Next door, we had a patient, we had a student that was hyperventilating because she thought, in the morning she thought she had cancer. By lunchtime she had some other type of immunity disorder, and she was just freaking out because she had this pain in her back. Okay, so she started breathing really fast. Her arms became very tingly. She got lightheaded, and that's all the effects of hypocapnia, meaning the blowing off too much CO2. And so she started freaking out. We had another student downstairs, I told you guys from the other class, that passed out. Okay, yeah, you probably heard about it. They passed out. So anxiety accompanies a lot of these things. Constipation, constricting edema. What's constricting edema? When you retain so many fluids, guys, let's consider our lower extremity for a little bit. If we have a lot of edema right here, the tissue's high in the mid portion of your lower extremity, but then it's so tight that it's constricting the blood flow. So that's constricting edema. Depression's a big one. Diaphoresis, we all know what diaphoresis means.
Sweating.
Yeah, excessive sweating. Diarrhea, distension, dry mouth, dyspnea, fatigue, fear, flatus. We all know what flatus means.
Yeah.
It's gas, okay? Gas, like before you fall, okay? So that's flatus. Make sure you know what that is. grief, headache, and of course hopelessness. We also have a patient experience hyperthermia, hypothermia, hypoxia, incontinence, muscle cramping, nausea, pain. Powerlessness is a big one as well. You guys know what pruritus is?
Yeah, itching.
Yeah, it's excessive itching. A lot of itching in your body. So if you don't know what that means, please write it down right now. Pruritus is itchy. Retention, sadness, singultus. What's singultus? Hiccups. Okay. Thirst and vomiting as well. The nurse should pursue methods to assist the patient in achieving relief from discomfort, actively listen to the patient, recognize discomfort signals even when the patient cannot verbalize them. What are some manifestations of being this uncomfortable in the patient? Let's say they're in bed. What might it be? Yeah, increased heart rate. What else? Non-vital signs. Their facial grimacing, if they keep tossing and turning a lot, okay, restlessness. Be diligent in efforts to relieve patients' discomfort. If interventions are not successful, pursue alternative interventions. Nature of pain. It's a complex, abstract, personal experience. That's very important for you guys to understand the concept. It's going to help you guys answer questions as to whether, if you feel the patient, again, is seeking medication, like drug-seeking behavior, we don't care about that. We don't focus on that. That's not our job, to not give them medication because they're addicts. We have to treat them if the manifestations are there. Okay, because pain is what, objective or subjective? Subjective. An unpleasant sensation caused by a noxious. You guys know what noxious is, or noxious? It's noxious, actually. You guys know what that is? Something like that, like something bad. It's bad for you, like poisonous. It's just an ill feeling. Okay, that's what noxious is. Caused by a noxious stimulation of the sensory nerve endings. Serves as a warning system to the body because it often occurs when there is actual or potential tissue damage. That's very important for you guys to understand. The whole concept of pain, it's to remind us that, hey, our body or that limb is in danger. So if there's an infection, there's a lot of pain, it's because it's letting us know that the tissue might be compromised. Okay? So please highlight that or underline that. It may be a cardinal sign of inflammation. That's really important for you guys to know. You guys know what cardinal means? Yeah, like utmost importance, yeah. A cardinal sign of inflammation. Please know what that word is, okay, guys? Be able to recognize it later on. It's valuable in the diagnosis of many disorders and conditions, of course, and it can occur when there is no tissue damage, such as pain of grief or the pain of a migraine headache. Again, the nature of pain. Pain is subjective. It's a test question, guys, so please know that. The interpretation and significance of the pain depend on the individual's learned experiences and involve psychosocial and cultural factors. Again, I was talking about my mom having high tolerance to pain. My daughter apparently has high tolerance for pain as well. I told you guys she was sick. She had the ear infection. When the doctor went in with the otoscope, she said, you know, the eardrums are really inflamed, but she's not pulling on her ear. And at home, she wasn't pulling on her ear either. So she has high tolerance to pain. Only the person who is bearing the pain is an expert about that pain. That's why we always give medication. These are all concepts that you guys have to understand. A patient with pain does not always know how to report the pain to health professionals. The nurse has a major role in helping the patient by conducting nursing pain assessments. Okay, we'll talk about that in just a bit as well. So by definition, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Okay. The International Association for Study of Pain, the IASP, and the American Pain Society, APS, define it as, I'm not going to test you on those, but just know them. We have different types of pain, mild and severe. What's mild? You guys know what tool do we use to determine the amount of pain that the patient's in? The phase scale, the 0 to 10, right? We have a few. The most common one is the 0 to 10, right? Patient has zero pain. What does that mean?
Happy.
Okay, they're happy. They're no pain, right? If they have a 5, what does that mean?
Mild.
Excuse me? Mild. Yeah, it's actually a little bit more moderate. I want you guys to know, write this down. A patient can no longer function actively after their pain scale is a 4. Okay, after the pain is a 4, They can no longer function anymore. In the sense of, in this meaning, in this sense, like if I have pain in my foot, let's say, if it's a 2 or a 3, I can still walk on it occasionally. Okay, but you guys ever had a hangnail? You tear it out, eventually it gets inflamed. It comes to that point where you can't even step on that foot. Okay, that's what it means theoretically speaking. Once the pain is a 4, we have to do something about it. Whether it's guided imagery, whether it's morphine, whether it's some type of invasive or non-invasive medication or treatment, we have to perform something. Okay, critical number. Yeah, 4 and above. So mild meaning it's maybe about a 3, 4. Okay. Severe, of course, is 9, 10, the worst pain you've ever experienced. What if a patient tells you, my pain level is a 10? What do?
You record it as a 10?
You record it as a 10. Okay, you record it as a 10 because pain is subjective. Intermittent or intractable. What's intermittent? It comes and goes, comes and goes. Intractable, doesn't go away. Burning, dull, or sharp, precisely or poorly localized, and referred. You guys know what referred pain is? Okay, let me talk about... Yeah, like I'll give you guys a perfect example referring to your chest. So if you have, we talked about the cardiovascular system, we talked about the blood pumps, the heart pumps blood all over the body, right? So if you have a heart attack, okay, what are the key, where do you usually have pain? Okay, the back, the chest, what arm? Usually the left arm, right? And it radiates down. Radiates means it travels, okay? That would be an example of referred pain, okay? Is there something going on with your arm? No. But because of the heartache, we've known that over and over, whenever someone has a heart attack, they have referred pain. And this referred pain is caused by the heart attack or the angina. Or they have referred pain on their lower jaw. Does that make sense? Okay. So please know what referred pain is. I'm going to test you on it. Alright, getting more specific on types of pain, we have acute and we have chronic. By definition, guys, acute would be sudden onset or less than 6 months. Okay. Chronic pain, by definition, is anything that lasts 6 months or more. By definition. Let's talk about acute pain. Acute pain is intense and short in duration. Usually lasts less than 6 months. Generally provides a warning to the individual of actual or potential tissue damage. Now that's very important for you guys to know for acute pain. Okay, acute. It gives a warning sign. It serves as a warning. It creates an autonomic response that originates with the sympathetic nervous system. It floods the body with epinephrine, that fight or flight response. Okay. I'm sorry, what? The fight or flight. Oh, epinephrine is a hormone, guys, that, remember we're talking about the nervous system? Talked about the autonomic, the sympathetic, the parasympathetic nervous system. Anyway, I won't go back to that. But which organ or which gland secretes these epinephrine and norepinephrine? You guys remember? Adrenal glands. Yeah. Your adrenal glands for your adrenaline. The epinephrine is also known as adrenaline, right? So whenever if tissue damage is going to occur, you need to do something quick, right? So that's that whole epinephrine, that fight or flight. It gets you ready to do something about it. That's all it is. Okay, chronic pain lasting longer than 6 months, again by definition, can be continuous or intermittent and may be as intense as acute. So that's not cool. Does not serve as a warning sign of tissue damage. So please remember that, guys. The warning sign for tissue damage is just going to be acute pain, not chronic. Patient may develop chronic low self-esteem, change in social identity, changes in role and social interactions, fatigue, sleep disturbances, and depression. Why does that happen? Okay, that's a little more specific though. Why do you guys think, if I have pain for a long time, okay, no one else knows about it, why is that going to affect my social dynamics, you focus on it a lot, you get depressed, and you can't do anything. You can't go, yesterday I went out and played pool and I had like a couple beers, you can't do that anymore if you have liver cirrhosis. You feel me? You can't do those things if you have chronic pain. So that's why. How about sleep disturbances? Why sleep disturbances? Yeah. My mom suffers a lot from pain. My mom's worked her whole life. She cleaned houses. I was gonna say she mowed lawns, but that was my dad. My dad mowed lawns too. But my mom and my dad are all beat up because they worked hard for us to be, have a better life. But my mom has a high pain tolerance, but she's always in pain. Sometimes so much that at night she won't tell you I'm in pain, but she just won't go to sleep. Okay, so that happens a lot. Some theories about pain transmission. When we talk about a theory, what's a theory? What does that mean? It's a possibility. It's something that we get like signs and we get information, and we build up a theory, a thought process as to why this happens. That's what the theory of pain transmission is. Do we really know? No. All right, something called the gate control theory. This is very important for you guys to know. Highlight it, put a star next to it. You guys, please read this on your own as well. The theory suggests that pain impulses can be regulated or even blocked by gating mechanisms located along the central nervous system. What that means is that if I have pain in my hand, okay, because I got stabbed or something, right? So I have pulsating pain, I have inflammation. If my wife comes up and starts rubbing my shoulders, okay, or if my wife gets mad at me and smacks me across the head, either way, okay, that stimulation will trick my brain to focus on that, and it'll sort of forget about the pain in my hand. That's the gateway theory. The gate theory. The gateway theory. That's weed juice. I'm sorry. Okay, the proposed location of gates are in the dorsal horn of the spinal cord. Please know that. Dorsal horn of the spinal cord, when you transect the spinal column, not the spinal column, a vertebrae, they look like little horns on the top, and I don't have an illustration of it, but just know it by definition, okay, guys? Pain and other sensations of skin and muscle travel to the same pathways through the large nerves and the spinal cord. So again, it's not only the pain, but it's all. Remember we talked about afferent, efferent neurons that send transmissions of sensory versus motor movement. So they all travel to the same spot. Pain and just regular sensory. So if I have pain here, I just start a little rub my shoulder or something like that. Usually it blocks that pain because the brain starts focusing on that. Does that make sense? Okay. If cutaneous stimuli, what's cutaneous? Okay, if cutaneous stimuli other than pain are transmitted, the gate through which the pain impulse must travel is temporarily blocked by the stimuli. You guys know what we use for that? Sodium ion. Came out of nowhere. I'm like, what?
I see a thing where they actually blocked it.
I have no idea.
Okay,
So
I'll bring
no. Yeah, bring it. No, what I was talking about is something called a TENS unit. You guys ever seen the little electrodes they put on? You guys ever use those in elementary school? I don't know, we used to use them because it was cool. Or junior high, no? We went to different junior highs. Okay, it's a little apparatus, a little box as big as a cell phone, and it has these knobs on them, and it sends an electrical current. So people that have chronic back pain or something, what we do is the chiropractor will give it to you. It sticks onto your back, and it'll send little stimulations of electricity. Okay. Acupuncture is a little different. It's with the little needles, but it's very similar. It serves the same purpose. So it gives you a little stimulation. It's called a TENS unit, and we'll talk about it in a bit. It's used to perform that whole gate theory, to stimulate your brain otherwise, so you won't have that chronic back pain or anything like that. The brain cannot acknowledge the pain while it is interpreting the other stimuli. So that's the main concept that I want you guys to understand. A bombardment of sensory impulses, such as those from the pressure of a back rub, the heat of a warm compress, or the cold from ice applications, will close the gates of pinful stimuli. Okay. Some patients can be distracted from pain by removing the sensation of pain from the center of attention. Auditory or visual stimulation can distract patients and help make pain more tolerable. Okay, it doesn't work with all patients, but with some of them it does. And if the patient's in chronic pain, they're a lot of pain, and you try to do something like that, I'm not saying it's corny. We talk about it because it is effective, but be careful though. Don't go straight. Know your patient first. If they're in a lot of pain and they're very irritable, don't go, ma'am, I want you to imagine you walking down the beach. Don't do that, okay? Just ask them questions about their lives. And if they get irritated, they'll just tell you, I don't want to talk, and that's fine. But don't get caught with the whole, thing about the beach and all that. And have them throw water at you, okay? What kind of auditory stimulation can we provide? Yeah, usually some rap music will do it. Okay, how about visual stimuli?
TV.
Yeah, usually TV, anything like that. Okay, the gating mechanisms can also be altered by thoughts, feelings, and memories. So that's why I say, if you have a patient that's very irritable, you know that this might not work. You sit down and you tell them to visualize the beach. Just ask them questions. So where were you born? Yeah. Where did you're married? Oh, really? Where did he propose? You know, things like that. Okay, about them. Figure 16-2 just illustrates. It's a poor illustration, guys, but if you look at them, they all look the same. Essentially, what the first one is saying, the top one, is saying that that little line that goes from the spinal cord to the brain, that's the pain. Okay. The other one, you see how there's two waves on that spinal cord section? Okay, it's saying that it's blocking the gate so that stimulation can't get to the brain. We don't know that we're in pain. Alright. You guys work out? No. Okay. I try to work out about once a week. Okay. When you work out, how do you feel afterwards? Aside from sore, you feel pretty good, right? You guys are fresh. You feel fresh. You guys ever go running? Okay, like somewhere out in the wilderness, you feel great. You feel the wind hitting you. You feel your hair, well, my imaginary hair waving all through the place. But you feel good. Your body releases something called endorphins. Okay, endorphins are other little chemicals in your body. These are your feel-good. Okay, your feel-good endorphins. That's why a lot of people get really addicted to working out. Okay, we get little glimpses of it, and we don't do it often. Well, at least I don't do it often enough to really be all an addict of endorphins. But when you work out, your body releases endorphins. Also, when you're in pain, or when you get in a car accident, or when you sever your leg through some type of accident, your body releases endorphins because they're your feel-good chemicals. So they make you feel good. They block the pain. That's what it does. So the body contains a natural supply of morphine-like substances called endorphins. Please know what endorphins are, okay, folks? Stress and pain activate endorphins. So when your body's working out, that's stress. It releases endorphins. Analgesia results. Oh, what's analgesia mean? Numbing? Okay, yeah. Taking away of pain, yeah. Analgesia results when certain endorphins attach to opioid receptor sites in the brain and prevent the release of neurotransmitters, thereby inhibiting the transmission of pain impulses. You guys remember what neurotransmitters are, right? Neurotransmitters are the chemical messengers that go from one neuron to another. It gets blocked with this. Okay, so please know what endorphins are, guys. Know that it makes you feel good. They're morphine-like substances. Our body generates them themselves. Okay. Any questions on endorphins? No? People who have less pain than others from a similar injury have higher endorphin levels. Pain relief measures such as transcutaneous electrical nerve stimulation. That's the whole TENS unit, guys. TENS stands for each one of those words respectively. Acupuncture, you folks know what acupuncture is? Little needles coming in your back. And placebos, you folks know what placebos are? Okay. Are believed to cause the release of endorphins. That means that that one little experiment that I had with you guys a few weeks ago, it's actually it works. Because your mind has more control over your body than anything else. Use a pain rating scale that allows... Oh, wait, am I in the right one? Okay, making pain the fifth vital sign. Please know that pain is the fifth vital sign. I think we talked about that before, but just remember that. Making pain a vital sign. This is a test question, okay, folks? Along with the pulse, temperature, blood pressure, and respirations, it would ensure that the pain is monitored on a regular basis. So anytime you take vital signs, guys, that's the fifth one. Okay, it's the fifth one. Do you guys do that at the facilities now?
Yeah.
Okay, make sure you continue to do that. Use of a pain rating scale allows patients to clearly articulate their pain and makes them more likely to receive proper treatment. Excuse me. Scale of 0 to 10, in which 0 is no pain and 10 is the worst pain imaginable. Alright, read that. Let me see. I'll just read this real quick. TJC, guys, the Joint Commission. Under the new standards of the Joint Commission, healthcare providers are expected to be knowledgeable about pain assessment and management, and facilities are expected to develop policies and procedures supporting the appropriate use of analgesics and other pain control therapies. What this means is, remember we talked about that there's nurses for infection control? Okay, so now there's a group that monitors the hospital's pain regularly. So if they say, every time we document what the patient's pain level is. So the Joint Commission comes in and it looks at the charts or the electronic ones, and they see if the patients are always in high pain, we get dinged for it. We get penalized for it. So that's all it means. Okay, key concepts to remember: patients have the right to appropriate assessment. Patients will be treated for pain and referred for treatment as well. Pain is to be assessed and regularly reassessed. Patients will be taught the importance of effective pain management. Patients will be taught that pain management is a part of treatment. And patients will be involved in making care decisions as well. So a couple of key concepts that the TJC has come up with, but this is going to apply for you guys forever. Routine or PRN analgesics are to be administered as ordered. You guys know that even you guys know what PRN stands for? Okay, as needed. You guys know that even the PRN medications, they have parameters, right? Okay, meaning you could give one every 8 hours or every 6 hours. It's not on the schedule, meaning you only give it as needed. Discharge planning and teaching will include continuous care based on the patient's needs at the time of discharge, including the need for pain management as well at home. Let's talk about, you guys good? You guys with me so far? Okay. Non-invasive pain relief techniques. What does non-invasive mean? Yeah, not going inside the body, okay? Acupuncture, is that going inside the body?
Yes.
Yeah. So this is not what we're talking about. All right. Transcutaneous electrical nerve stimulation. TENS. T-E-N-S. Okay, that's what it stands for. Transcutaneous means what? It goes through the skin, right? Electricity, nerve stimulation. So we stimulate the nerve endings to block that whole pain receptor. Hence, proving the whole gate theory. It provides a continuous mild electrical current to the skin via electrodes, and it blocks pain impulses. Please know what the TENS unit is, okay? The TENS unit is a little device. Know what it does, know what its whole purpose is, okay? Oh, just T-E-N-S, yeah. T for transcutaneous, E for electrical, N for nerve, and S for stimulation. On the exams, you'll probably see it as a TENS unit, so please know what it is. Alright, so it offers distraction, it offers relaxation. We have guided imagery as well, hypnosis, and biofeedback. You guys know hypnosis is real? It's legitimate. Not everybody's prone to hypnosis though. That's the thing. All right. What's biofeedback? Biofeedback is you keep asking them questions about their pain and how it's getting better. You kind of find closed-ended questions to have them continue to talk about their pain and how it's getting better and things like that. It takes their mind. Supposed to take their mind off of it. Some nursing interventions, invasive approach to pain. So this means we're going in, we're doing something, right? Nerve blocks, epidural analgesics, neurosurgical procedures, and acupuncture. These are all considered invasive. And then we have medications for pain management. We have non-opioids. You guys know what non-opioids are?
Opium.
Yeah, opium is a drug from a particular plant. Okay, it's very strong. They're considered narcotics. They're the ones that are locked at the hospitals. Non-opioids are the ones that you can go and buy over the counter. Okay. Yeah. So non-opioids, acetaminophen, which is also known as Tylenol, and non-steroidal anti-inflammatory drugs, Nsaids. And they include aspirin, ibuprofen or Motrin, and naproxen sodium. These are all medications. Now, I want you guys to write something down, okay? When it comes to Nsaids, they're non-steroidal anti-inflammatory drugs. What did we say about medications like Solumedrol? Do you guys remember? Or did I not talk about that with you guys? It must have been another class. All right. Medications like Solumedrol, they're steroids. They're corticosteroids, and they decrease inflammation. But they're very powerful. They're very similar to what your adrenal glands produce. Remember we talked about the cortex? It produces corticosteroids. So these type of hormones, they decrease inflammation in your body. Now, if you introduce a chemical that's very similar to that, your body's going to read it, right? And it's going to detect it like as part of its own body. So it's going to either increase or decrease its production based on the amount of availability in the bloodstream. Does that make sense? So, bless you. But the problem with steroids, this isn't like anabolic steroids that people use to work out. These are just other type of steroids, okay? These are steroids very similar to the hormones produced by your adrenal cortex. Now, they're very powerful. And if they're very similar to the hormones, they're kind of delicate to use. But they bring down the inflammation. That's a great thing. Like if somebody has severe inflammation, we give them steroids and it brings down the inflammation. Now, Nsaids, it's non-steroidal. anti-inflammatory agents. They also bring down the inflammation, but they don't have any steroids, meaning it doesn't mess with the cortex. It doesn't trick your body into thinking that it's releasing its glucocorticoids or mineralocorticoids. So in turn, it's really good to decrease inflammation, but it's not as strong. Does that make sense? But one thing about Nsaids, or non-steroidal anti-inflammatory drugs, is that it irritates the stomach a lot. So please remember that if you ever give a patient Motrin, okay, aspirin, naproxen, any type of those medications that are considered Nsaids, you want to make sure that they have something in their stomach. Okay, does that make sense? So whenever giving Nsaids, you want to make sure that they have something in their stomach. Write that down, please. Okay. Whenever you give Nsaids, you make sure that it's not on an empty stomach and you give them something to eat. Okay, because it irritates their stomach. If a patient has ulcers, you guys know what ulcers are yet? Okay. If a patient has ulcers or bleeding of the tissue inside the stomach or the duodenum, you don't give Nsaids. In particular, you don't give aspirin. You guys know what aspirin is? Okay, it's a medication. What do we use it for?
Blood thinner.
Particularly, blood thinner is the other function that we have. Yeah, it thins out the blood a little bit, not too much. But we usually give it to patients that are prone to some type of cardiac issues because of atherosclerosis or arteriosclerosis. So it thins out the blood. If you have an ulcer, what's it going to do to the blood? It's going to thin it out and means it's going to bleed more. So that's why you never give Nsaids on a patient that has any type of ulcers or any GI upset. Does that make sense? And you always give it with food. All right. They're the most widely available and frequently used analgesic groups, and they're used primarily for mild to moderate pain. Okay, once you get to the severe pain, what do you use? You go to the, no, not necessarily, the opioids, yeah, the opioids. If you have severe inflammation though, yeah, you do. Okay. Any questions on non-opioids? Okay, anything that's not a narcotic, okay? Alright, let's talk about opioids. Medications such as morphine, Demerol, and codeine. These are all feel-good medications, okay? They really do the job. The problem is that these medications work so much on your nervous system, guys, that it sometimes depresses it if you give too much. So you guys know which vital sign morphine affects? Yeah, respirations. Please know that, guys. Write that down. Morphine affects respirations. So if you give morphine, you always assess respiratory status or the breaths per minute. Okay? If the patient's breathing at 12, do you give it?
No.
No, because 12 is now considered
No.
bradypnea. Yeah, low bradypnea. Okay? Guys, I talked to you guys about Philip Moore, whatever his name is, the guy that OD'd on heroin. Okay, it turns out some guy OD'd on heroin. You guys hear about that?
Yeah.
Anyway, so he OD'd on heroin, but this new heroin has fentanyl in it as well. It's laced with fentanyl. You guys know what P-dogs are? Yeah. Why would you know that? Why would you? Huh? Because he lives on Holt. So look, back in the day, what kids used to do is cocaine is expensive and it's a hell of a drug. So what they would do is they would get marijuana and they would lace it with either crack or cocaine. That's called a P-dog. So it gives you a down and an upper. So anyway, the whole heroin, guys, the heroin was laced with fentanyl. Fentanyl is a narcotic. So it kind of like piggybacks on the morphine, on the heroin's effect. So that's why he ended up dying. They say that we don't know if he knew that it had fentanyl in it, and a lot of people, I think in the East Coast, over 40 people have died ever since. Yeah, it increases the effect. It makes it more potent because heroin's a downer, right? So fentanyl is a pain reliever, and any type of opioids will affect the nervous system, so it's going to be like a hell of a kick. It's really strong. Yes? Excuse me? He said a year ago, I read somewhere that he said a year ago that he fell off the wagon, that he started using, again, but he was shooting up. So shooting up. What's quicker, guys, smoking it or shooting up? Yeah, it becomes systemic real quick. So don't do heroin with fentanyl or P-dogs. Okay. All right, tolerance. You guys hear how many, let's talk about tolerance real quick. You guys hear how many bags of heroin he had on him? 50. 50 bags of heroin. But I also read that that's not a big deal. I'm like, okay. Some people can go through 50 bags like in one day. I guess so. It's because of tolerance, guys. Tolerance. Philip Seymour Hoffman. He's an actor. I like him on Boogie Nights. He was cool. Anyway, tolerance, guys, develops after a while. So we have a patient at Kindred. I was about to say her name. But anyway, HIPAA. She has end-stage renal failure, but she's alert and oriented, just like you guys. You know, her husband's a cool guy. He's there every day. He's been there every day for 3 years now. Hats off to him. Anyway, but I remember when she first came in, the amount of she likes her Dilaudid and her what other medication does she take? I forgot now, but it's an antihistamine, and her Benadryl IV, and I remember before it was like 0.5 milligrams of Dilaudid. Now it's like 3.5, 4 milligrams. Okay, and it'll continue to go up because your body develops a tolerance to it.
So it doesn't usually do anything to your body, so you have to put more.
No,
it gets used to the amount.
Well, remember this drug, what it does is it blocks the nerve receptors, okay, and it slows everything down. The whole problem is that if you give too much, you're gonna die. Now the high that people get is the high that they feel because you guys ever had morphine? You guys ever had morphine? You'll know what I'm talking about. You feel like a warm blanket just went on your back, and you feel high. Okay, it feels good. It feels nice and warm and cozy. But if you take too much of it, that'll be the last one. Wow. Did they give you a epidural?
Yeah.
Before that? Mm-hmm. That's why. Why did they give you morphine?
I don't know. I had to have them call the doctor because they just kept giving it to me, and I'm like, it's not working.
Yeah, that's bad nursing, guys. It's not going to work. She has a nerve block.
Right.
Her nerves are blocked, so...
I was starting to feel everything because that just came out of my C-section.
Oh, wow.
So the epidural was wearing off. They were giving me morphine. It wasn't working.
Yeah, it's not going to do anything. That's wild.
Wow.
Don't be that nurse, guys. So again, tolerance and physiological dependence are unusual with short-term post-operative use, and psychological dependence and addiction are extremely unlikely after taking opiates for acute pain. Okay, it doesn't really talk about what happens for chronic use, guys, but I'm letting you guys know people do develop a tolerance, therefore they have a dependency on it. But research shows and suggests that for you to become addicted to these type of medications, you have to have something else going on in your life. Something else that's bad, and you have to have an addicted type of personality. Luckily, I don't. Okay. Anyway, pain mechanisms affected by each analgesic group. Alright, non-opioids. What are we talking about without looking at it? Non-opioids.
Not narcotics.
Not narcotics, Nsaids, Tylenol, right? Alright. They exert analgesic or pain-relieving effects through the inhibition of prostaglandin production. Okay, prostaglandin is a chemical in your body that transmits pain impulses. So what it does is it stops the production of the prostaglandin. Okay, that's pretty much all you guys have to know about that. I don't think I test you on that, but just know it just in case. Opioids relieve pain mainly by action in the central nervous system, binding to opioid receptor sites in the brain and the spinal cord. What part of the spinal cord? The dorsal horn. Okay, please remember that. And then we have adjuvant analgesics. Adjuvant, guys, is just anything else. Anything else that we can come up with. Composed of diverse classes of drugs that relieve pain via a variety of mechanisms. Okay. I want you guys, this is what I'm going to be testing you guys on. Give me an example of an NSAID. Tylenol, okay. Actually, Tylenol is not an NSAID, guys. Okay, no. It's not. There you go, aspirin. Let me take that back. Non-opioids, we have aspirin. We have Tylenol and Nsaids. Non-opioids. Okay, Tylenol is considered an antipyretic. It has analgesic effects as well, but naproxen, ibuprofen, aspirin, those are considered Nsaids. Okay, Tylenol. If a patient has an upset stomach, you can give them Tylenol. Okay, Nsaids you cannot. Please know the difference. You guys called it because you guys remember seeing it, but it was under the umbrella of non-opioids. So you have Tylenol and then you have Nsaids. That's two separate categories. Does that make sense? All right. That's what I want you guys to know. That if I say what's a non-opioid, either whether you tell me it's Tylenol or Nsaids, that's fine. If I say opioids, morphine, okay, things like that. And adjuvant analgesics is just anything else. I'm not going to test you on that. All right, some nursing interventions for this. You guys with me so far? All right. Preventing and managing opioid-induced constipation. This is something that happens, guys. So if we give opioids, okay, a lot of medications, a lot of opioid medications are really strong, and they, bless you, and they decrease, in general, everything. They bring down your blood pressure, they bring down your respirations, they bring down your heart rate. Okay, it also decreases the motility of your intestines. Does that make sense to you guys? Motility is the movement, okay, the peristalsis, so you can continue to digest. So if you have a patient that has a chronic pain, and they have they've had morphine for like the past 4 days, what are they at risk for? Constipation. What can you guys do to prevent that? You give them fluids. What else? Before we start talking about like, oh, we give them a stool softener, before that, what else can we do? High fiber diet. What else? Repositioning. Look, guys, if you guys have a patient that is an opioid user, not like an addict, but I'm saying they're receiving opioids and they're at risk for constipation, you have them ambulate if they can. If they can't ambulate, you reposition them. You do something to move everything around. Okay, that's what we actually usually do. When a patient's post-op and they just had a surgical procedure, the first couple things, as soon as they can walk and they have a gag reflex and all that, we have them mobilize. We have them ambulate so the peristalsis can continue, the motility of the intestines can continue, and they can defecate. Usually they don't do it till 2-3 days afterwards though, because everything's slow. Alright, where was I at? Alright, so opioids can delay gastric emptying. Oh yeah, opioids can delay gastric emptying, slow bowel motility, and decrease peristalsis. Opioids may also reduce the secretions from the colonic mucosa, results in slow-moving, hard stools that is difficult to pass. Have you guys ever seen a patient that's constipated? Now, have you ever seen their rectum or their anus when you have to do like a digital extraction? Sometimes, guys, this is so bad, and constipation, and you'll see this at the hospitals, is one of the things that is mostly overlooked by nurses, because we're like, the next nurse will get it. And I'm not saying because I'm the one that did this, but I saw it at the hospital a lot, and I participated in it a lot as well. Like your first day, the patient's constipated, and you're like, they'll have a bowel movement tomorrow. Next thing you know, you come back like after your break. I'm talking about your 3-day break. You come back and you look at the chart, still no bowel movement. Okay, the stool gets rock hard. Okay, it's no longer moving because the intestines are peristalsis wants to move, but it's not happening. The colon dilates because of the impaction of the stool. And what do you guys have? What do we have to do?
Take it out.
Yeah, we have to take it out somehow, guys, because it stimulates the vagal nerve, it brings down the blood pressure, the heart rate, and the patient can pass out. Okay, so what we have to do is we go in there with our hand and we extract it out. You have to extract it, and they're rock hard, folks. They're rock hard. And I'm not saying this happens all the time, but we do it. It's called a digital extraction. You have to be very careful when you do it, because aside from the patient straining, stimulating the vagus nerve, while you're in there, you can also stimulate the vagus nerve. So you want to do it in maybe for a minute and then
But
stop.
before that, you'll try different things, or
Yeah, I'm talking about this is like the end result. This usually happens if you don't do something about it before. You can give them enemas, it won't work. It won't work.
Yeah, well, we had a patient like that last week, and they're like, you want to do it? You're going to be a nerd? I said, I'll go to lunch.
You have to go to lunch? You did it afterwards?
No, I was there, but I didn't do it.
Oh, okay.
And it
was bad.
rock hard.
What happens, guys, and then the anus it dilates because the patient, the body wants to get rid of it. So you have an open anus like that, and you see the you see fecal matter. Mm-hmm. If they weren't there, you'd see everything else. Though. All right, gastrointestinal dysfunction can result in ileus, fecal impaction, and obstruction. Okay, you guys know what an ileus is? Ileus, yeah. Ileus is an obstruction, guys. It's just what it's called. It stops functioning. It's an obstruction. A preventative approach is something we should be considering. Regular assessment and aggressive management are required. If your patient's been constipated, folks, for more than a day, it's time for us to do something. Okay, if the patient has anything prescribed, we start giving it. We don't give at first an enema. The enema is the last thing you give before you actually do a digital extraction. But you give stool softeners, or before any medications, again, we try mobilizing the patient. You want to give stool softener, okay? All right, administration routes for analgesics. You guys with me so far? I'll turn it on. I want you guys awake. And me awake. All right. IV. It's a route of choice because it's quick, it's effective. All right. Route of choice for opioid analgesics after major surgery, bolus and continuous infusion. You guys know what a bolus is?
Yeah.
Okay. Yeah, Miss. Oh man, I went blank on your name. Don't tell me. Don't tell me. Why can't I went blank on your name? Yeah. Susan Holmes. Okay, I'm sorry. I didn't even hear you. Sorry, guys. All right, Miss Susan, you said after your C-section, you had a C-section, right? They gave you a lot of shots of medication, of morphine. Each shot of those guys is considered a bolus. It's just an unspecified, or in her case, it was a specified amount, but just a specified amount. That's a bolus. Okay? Sorry about that, Miss Holmes. Or continuous infusion. You guys know what a continuous infusion is? You guys ever heard of
Like continuous feeding?
Excuse me?
Continuous feeding?
Like a continuous feeding? Yeah, but this would be for medications, though. Okay, this would be for
like
medication.
morphine?
Yeah, like a pump, like a PCA, okay, things like that. So again, IV is the quickest way, the most preferred method. IM, unreliably absorbed, painful and traumatic, may cause fibrosis of muscle and soft tissue. If you have a bad nurse, if you have a nurse like me, you'll be fine. All right, now for patients who have regular pain, we can start getting them on PO medications, PO analgesics to the mouth, and it's pretty reliable, folks. Okay, oral is the optimal route, especially for chronic pain. Convenient, flexible, and relatively steady blood levels, appropriate to use as soon as a patient can tolerate oral intake, and the mainstay of pain management for ambulatory surgical patients. So please understand. Please know that IV is the quickest, okay, and it's good for acute severe pain, but when it comes to chronic pain or just to maintain the blood levels relatively normal, oral administration of medication is the preferred, okay? We also have something called a PCA, or a patient-controlled analgesic. That's when the patient has a little pump right next to their bed. They have a fat syringe of morphine in there, and you push the little button. Okay, and it's calibrated in such a way that you can't give any more than a certain amount, so you won't OD. But what's the advantage of having a PCA?
You can overuse it.
Excuse me?
You can overuse it.
You cannot overuse it because it's set up. Yeah, it's set up. I mean, imagine if like they didn't set it up. Like no. What ends up happening is it's calibrated. It's set up that you can't give any more than, like, let's say a gram for every 3 hours. So the advantages are that the patient has more control, autonomy. The patient doesn't have to wait on the nurse, okay? And they feel like they have more control over the whole situation. And hopefully it'll steady the pain a lot better. So those are the advantages. Know the advantages of having the PCA. I'm going to talk about that right now. Yes?
Isn't that the same as a bolus?
No. It would be like this. I receive a bolus every time I push the button. Do you see what I'm saying? It's not such a specific definition. I saw bolus there. I want you guys to know what it is. It's just an amount of medication. Yeah, when you have a PCA pump, every time you push it, it gives you a bolus of medication. Yeah. All right, so this drug delivery system allows patients to administer pain medications whenever needed. Analgesia, or pain relief, is more effective when the patient, rather than the nurse or physician, is in control. Patient must be alert, oriented, and able to follow simple directions. Okay, but again, it's calibrated so you won't give any more than what's suggested by the physician. A lot of the times, the patients will complain that, I worked with this one nurse. I'm gonna say her name. Her name is Shelly. Okay, that's all I'm gonna say though. And I made up the name, by the way. But anyway, it was really hard to work with her because she didn't give her patients the medication like right when it was time. And mind you, she wasn't busy all the time, and it was, I wouldn't say that, but it was really hard because guess who had to give it? Okay, when you guys are working on the floor and you're working with a nurse that's not tending to their patients like they're supposed to, you have to pick up the slack. And I say you have to because if you're an ethical person, even though the nurse is messing up, but who's suffering for it? The patient. All right, so keep that in mind. Let's see, administration routes for analgesics. Epidural analgesia. What's epidural mean? Yeah, so in the spine, right? When we're talking about the meninges, the dura mater, the pia mater, the arachnoid, all that good stuff. All right. Insertion of an epidural catheter and the infusion of opiates into the epidural space. Okay. Medication diffuses slowly from the epidural space across the dura and the arachnoid membranes into the cerebrospinal fluid. So it mixes in with the cerebrospinal fluid. Maybe 10 times as much as a dose that would be injected directly into the cerebrospinal fluid. Side effects include, now know these side effects, okay guys? Know these side effects. It includes urinary retention because you have no sensation from that point down, right? Postural hypotension, pruritus or itchiness, nausea, vomiting, and respiratory depression. Okay, please know those side effects. Why do we get the urinary retention? Because you don't have no sensation. That's right. Okay. Figure 16-5 just shows you a little illustration of a catheter going into the. I think that looks like the lumbar spine. Now, you as nurses have a lot of responsibility. Pain management is a challenge that every nurse must face, regardless of the practice setting. The nurse's role in pain management is probably more important than that of any other member of the healthcare team. The nurse should advocate for the patient by clarifying concerns, answering questions, supplying all the information that the patient needs to make decisions about care, and supporting the patient's decisions. I've worked in several hospitals, and not a lot of nurses do that. So make sure that you're that nurse, guys. Listen, if you know your patient is one of those, we have difficult patients sometimes. We have patients that they request a lot from us, they demand a lot, they're rude. Okay, but think about where they're at. They're in a hospital bed, they're miserable probably, and we're out here working. We're supposed to be helping them feel better. So don't be that nurse, guys, that ignores the patient or that says, oh, they just want this. Don't be that nurse. Just smile and say, okay. You know, if for whatever reason you can't give it, just say we can't give it right now, and explain to them why. The parameters are set. We can't give it because your blood pressure might drop too low. Okay? But be a pleasant nurse, folks. The reason why I say this is because I've worked with a lot of nurses and they're not pleasant. It's like they passed the NCLEX, but they passed no social skills test. Okay? So please be the good nurse. Okay? I was always like, I felt the same that the other nurse felt, like the same way. Like, oh, this patient. But I never let them know that. Hell, I never even let my coworkers know that, because then they want to gossip with you, like, oh yeah, that patient, this and that. You don't want to partake in that, okay? So be that positive nurse. All right, collection of subjective data. Characteristics and descriptions. So we have to assess the site, meaning wherever the pain is at, the severity, 0 to 10, duration, does it come and go, does it last for several minutes, and location of pain. Ask the patient what relieves the pain. How can you ask that? What relieves the pain? What makes it better? Yeah, what makes the pain better? What causes the pain to be worse? What makes it worse? And what does not relieve the pain? Identify usual coping mechanisms and the patient's families and friends' expectations and appropriate behavior when in pain. Any questions thus far? No? All right. What are some examples of subjective data? Subjective.
Expressions.
Okay. Tachycardia. No.
Expressions.
Oh, I'm sorry. Yeah. Subjective. Okay, I'm sorry. Yeah. Subjective
you said
tachycardia.
subjective?
Yeah. Give me some examples of subjective data.
My head hurts.
Yeah. My head hurts. Whenever a patient verbalizes something, guys, that's subjective. Okay. That's always subjective data. Tachycardia. It's objective. Oh, something you observe is something that you measure, so it's objective. Vital signs are objective. Okay, guys. But anything that the patient verbalizes to you, please be able to distinguish the differences. I know we talked about that in the first half of term 1, but brush up on those skills again. Okay, subjective data is anything that the patient tells you, that they verbalize it to you. That's subjective. Okay, anything that you observe or you can measure, that's objective. All right, collection of objective data. Tachycardia, increased rate and depth of respirations, diaphoresis, increased systolic and diastolic pressure, pallor, dilated pupils, increased muscle tension possible, nausea and weakness. Changes in facial expression, frowning or gritting teeth. Now, if the patient is frowning, okay, what do you put in your when you're charting?
Patient is fine.
No. Okay. No, I'm sorry. I thought you said patient sad. I'm sorry. Yeah, that's exactly what you put down. Yeah, patient's frowning. Okay, patient is exhibiting facial grimace. Sorry about that. If they're gritting their teeth, you write down the same thing. Okay, they might need a bite guard. They clench fist, withdrawal, crying, moaning, and tossing in bed, fetal position, clutching at the affected body part, pacing. You guys know what clutching at the affected body part means? Yeah, you're holding. Okay. It's going to be a lot of questions, guys, like 8 questions at least on, we'll give you something like, is that objective or subjective? Okay, or which of the following is subjective, or which of the following is objective. So please brush up on those, okay? It's important for us to use different types of pain relief measures, provide pain relief measures before pain becomes severe. That's the whole goal. Highlight that one. Put a star next to it. That's a test question somewhere. Okay, though, you guys, come on, guys, focus. The second bullet point. The second bullet point on page 10, the first box. Okay, so you want to provide pain relief measures before the pain becomes severe. That's the whole goal. By the time it gets to what level do we start acting?
4.
4. By the time it gets to 4, we start doing something. Okay, I'm gonna turn on the area.
It was awesome.
Sorry. All right. Let's see. Consider the patient's ability or willingness to participate in the pain relief measures. Choose pain relief measures appropriate for the severity of the pain, as reflected by the patient's behavior. What that means is that work with them. Okay, if they're more receptive to watching TV versus auditory, or you telling them a story or something, just let them watch TV. Okay. If a patient is ineffective if therapy is ineffective at first, encourage the patient to try again before abandoning it. Please highlight that. That's also a test question. Okay. Again, if a therapy initially, if it's ineffective, what do? Try it again. Okay. I'm not going to ask you if it's the 5th time and if it's ineffective, do you try it again? No. Very basic concept. If initially it's ineffective, you try it again. We're not worried about, what about if it doesn't work after that? No, we're just focusing on that. Okay. Look at the questions when you read them. Okay. Keep an open mind about what may relieve pain. Keep trying, and you always want to protect the patient. What else is something that really relieves pain? You guys ever try humor? Humor, being funny, trying to be funny. A little joke here and there. All right, but be funny, not disrespectful. Be funny, not racist. Be funny, not vulgar. Okay, because there's a fine line, and I'm always treading over it. Okay, but they're patients, so it's okay. Patients are perverted people, guys. Just to let you know. For you females in here, be careful if you have that one patient that wants to grab up on stuff like that. And the things that come out of their mouths is wild sometimes too. But humor is very effective if you know how to use it. If you don't know how to use it, don't try it. We have all this other stuff that we've been talking about. But humor is very effective. At least it has been for me. All right. In 10 minutes, I'll let you guys go, and I'll give you guys a 10-minute extra long break because you guys have been so patient. Okay. The following nursing measures can be performed by the nurse to assist in pain control. All right, so again, tighten the wrinkled linen. Okay, make sure that there's no creases. Reposition drainage tubes or other objects on which patient is lying. A lot of the times they have Jackson Pratts. Remember we talked about Jackson Pratts? And we'll talk about them some more next week. The tubes actually start hanging underneath their body, and if they're lying on it, it'll put pressure on it. You could develop a sore like that. Okay, so make sure that they're not laying on anything. You want to place a warm blanket for coldness. Do your facilities have those microwave or those heater? No? Yeah, I know they didn't. I know. I've seen your facilities. But you will eventually. That's a lot of the facilities that we go to, they do have them, so don't be too worried. Loose constricting bandages, change moist dressings, check tape to prevent pulling on skin. That's a big one. Okay, not for forever. A lot of the times the tape is too constricted, and then we take it off and we tear the skin off. It happens more often than I'd like. Position patient in anatomical alignment. What does that mean? Not so much like we're going to put them like this. Nah, so if they're like this, you want to straighten them up a little bit. And I know you guys have seen those patients when you go in the room and they're like this. Okay, so you want to put them in anatomical alignment to decrease the stress on the body and to make them a little more comfortable. That's pretty much it. Check temperature of hot or cold applications, including the bath water. You want to lift, not pull the patient up in bed. Handle gently. That's really important, guys. Okay, you want to lift and not pull. If you're gonna elevate an extremity, do you pick or do you scoop? You always scoop, okay, folks? You always scoop. You don't want to leave no handprints there, especially if they have edema. Okay, if they have edema on their legs and you grab onto it, by the time you let go, you see your handprints in there. Don't do that. Position patient correctly on bedpan. That's a big one too. Okay, make sure. Have you guys practiced putting bedpans on each other? I mean, on the patients, on the mannequins. All right, make sure it's on right underneath their bottom, not on the angle, because it hurts a lot. And remember to go back. Avoid exposing skin or mucous membranes to irritants. Prevent urinary retention by ensuring patency of the Foley catheter. I want you guys to do that. With every patient you guys have that has a catheter, I want you to go in and just start, not pulling on it, but with your gloves on, of course, you start tracking. Okay, and make sure that it's not underneath the patient. It's not kinked in any way, because if it's kinked, it'll start backflowing again into the patient. That's really uncomfortable. Okay, it happened to my friend actually. One of my coworkers. She had surgery. She ended up in the hospital that she works at, and next thing you know, the patient, she was a little lucid, not too much, so she was still a little confused, and she started getting really antsy. And then lo and behold, the catheter was underneath her thigh, and it was kinked. So for the past 3.5 hours, she was just retaining urine. She only had like 20 mLs of urine. 20 mLs of urine. How many are we supposed to produce at least in an hour? At least 30, right? So 20 in like 3.5 hours. As soon as they unkinked it, she stopped being confused and she cussed everyone out. Okay? So yeah.
She didn't have that thing?
The clip, no. She was at a Greater Almani. You guys have been there before?
No.
I think they're closing it down. Just put it that way. Okay, prevent constipation by encouraging appropriate fluid intake, diet, and exercise, and by administering prescribed stool softeners. Let's just finish this up, folks. All right, sleep and rest. Sleep and rest. Okay, we deal with this a lot. Do patients sleep the whole 8 hours at night?
No, they don't.
No, we're in there giving them medications. We have to reposition the neighbor and things like that, so we get in the way of that, but it's a must. A patient at rest feels mentally relaxed, free from worry, and physically calm, free from physical or mental exertion. I talked to you guys about, they did this sleep study, and when we wanted to find out what dreams meant. Back in the 70s, we didn't know what dreams meant, right? We didn't know what the REM cycle that we talked about. So we didn't really know what dreams meant. So we did a lot of studies. So what we started doing is the patient, before they started going into the REM cycle, the rapid eye movement, we woke them up. We kept waking them up. So by accident we figured out that by the 3rd or 4th day, they started having suicidal thoughts. They became anorexic. They didn't want to eat. They became crazy. Okay, because they weren't getting that rest. If you guys remember this test question? If you guys have a lot of dreams at night, does that mean you had a good rest or no?
No.
It means you didn't, right? Because you get the REM and the light sleep. So the patient wasn't allowed to sleep at all. So that's how important your rest is for the patient.
So what does it mean when you dream?
No, now we have other. We found out that, you know how you daydream in the daytime and you dream at night? The brain waves are exactly the same. We still don't know exactly what it means, but I mean, people have their own interpretation. Anyway, but what I wanted to get at is that your patients, they're very restless, they're very apprehensive and things like that. It's because they're not getting their sleep, guys. So don't be too hard on them. Be aware of that. Okay, so again, a patient at rest feels mentally relaxed, free from worry, and physically calm, free from physical or mental exertion. Sleep is a state of rest that occurs for a sustained period. The reduced consciousness sleep during sleep provides time for repair and recovery of body systems for the next period of wakefulness. So essentially, when a computer goes to sleep, guys, you notice how it's no longer hot. Okay, essentially that's what our body's doing. Okay, sleep restores a patient's energy and feelings of well-being as well. Let's talk about, this is where we talk about sleep cycle. We've never talked about sleep cycle before? Never? Let's talk about it now. Alright. The sleep cycle essentially has two phases. Okay, so two phases in sleep cycle. You have the REM and the non-REM. I'll talk about those in a bit. Two phases. Rapid eye movement. REM. That means that the eyes are moving. You guys ever seen that?
Yeah.
With your kids or your family members?
Kids.
Loved ones? Okay, they're next to you. They're sleeping, but their eyes are moving all over the place. When their eyes are moving all over the place under the lids, that means that they're dreaming. That's their rapid eye movement stage. Rapid eye movement stage, or REM, is that cycle, and then the non-rapid eye movement is the ones where you're not dreaming. Now, the NREM is further divided into 4 stages through which a sleeper progresses during a typical sleeping cycle. Okay? Let's talk about the non-rapid eye movements, the stage 1. Stage 1 of the non-rapid. Are you dreaming on this one or no?
No.
You are not dreaming. This is this is where you actually get your rest. Okay, the non-rapid eye movement, you're not getting rest. Your brain's still dreaming and sorting out all the things that you went through throughout that day and interpreting them in dreams. Alright, so stage 1 of non-REM. It's the lightest level of sleep, lasts a few minutes, decreased physiological activity beginning with a gradual fall in vital signs and metabolism. A person easily arouses by sensory stimulation such as noise. If person awakes, feels as though daydreaming has occurred. Reduction in autonomic activities. Okay, step 2, period of sound sleep. Relaxation progresses. It's important you guys know stage 2. Okay, stage 2 is really important. Relaxation progresses. Arousal is still relatively easy, lasts 10 to 20 minutes, and body functions are still slowing down.
You're not dreaming at stage 1.
No, this is the non-rapid eye movement, so you're not dreaming, period. Okay. The non-rapid eye movement, guys, is a stage in where it lasts a lot longer than the REM, the rapid eye movement, but there's 4 stages on this one, so now we're on the 3rd one. Stage 3, initial stages of deep sleep. Sleeper difficult to arouse and rarely moves. Muscles completely relaxed. Vital signs decline but remain regular, last 15 to 30 minutes. Hormonal responses include secretion of growth hormone. So that's why they say it's important for kids to get their good night's rest. I want you guys to know that in stage 3 of the non-REM is when deep sleep starts happening. Okay, so I want you guys to put a star next to this one, highlight it. Again, guys, we have 2 basic divisions. Rapid eye movement, dreaming. Non-rapid eye movement is when we start falling into deep sleep. The 3rd stage of non-rapid eye movement is that's when we start falling into that deep sleep or more difficult to arouse. And non-REM stage 4, the deepest stage of sleep, very difficult to arouse sleeper. If sleep loss has occurred, sleeper will spend most of the night in this stage. Let me read that again. If sleep loss has occurred, sleeper will spend most of the night in this stage. Restores and rests the body, vital signs significantly lower, lasts approximately 15 to 30 minutes, possible sleepwalking and enuresis. Hormonal response continues. Okay. Any questions on a non-rapid eye movement? Okay, what's happening in the non-rapid eye movement?
No dreaming. You're not dreaming.
Okay, you're not dreaming.
You're resting.
You're resting. At what stage do you start falling into that deep sleep pattern? 3. Okay, what 2 stages are you relatively easy to arouse?
1 and 2.
1 and 2. Which is the deepest stage of sleep? 4. This is again what? REM or non-REM?
NREM.
What are your eyes doing in NREM?
Not moving.
Okay, good. You're like an orchestra. Beautiful. All right, let's talk about rapid eye movement now. Okay, stage of vivid full color dreaming. First occurs approximately 90 minutes after sleep has begun. Thereafter occurs at the end of each non-rapid eye movement cycle. Okay. Let's see. Typified by autonomic responses of rapidly moving eyes, fluctuating heart and respiratory rates, and increased fluctuation in blood pressure. Loss of skeletal muscle tone occurs here, responsible for mental restoration. You see that one? Responsible for mental restoration. That's what we found out. If you don't let the patient dream, they're going to go nuts. By the 3rd night, they had to cancel the experiment because they wanted to kill themselves. They were trying to hang themselves. It was wild. Stage in which sleeper is... wrong one. Responsible for mental restoration, the stage in which sleeper is most difficult to arouse. Okay?
So this can happen all in one night.
Well, no, this does happen every night. Yeah, how many dreams do we have per night?
3.
I read somewhere that we could have up to like 15 to 20 dreams a night. Okay,
No
that
wonder
mean
I wake up. Mine is one dream goes the whole night.
the whole night. You guys ever had?
From childhood to end to die.
Oh, that's your
It's
what's
like
it called?
A movie.
No, that's life flashing before your eyes. What kind of dreams you have?
Not
just
the
teasing.
same all the time.
Oh, okay. You guys ever had those dreams where you wake up and you're pissed off? Like, I always dream that I'm flying. I always dream I'm flying, and I'm like so high, and then I wake up and I'm like, yeah, it's probably a dream. Yeah, I wake up and it's a dream. Anyway, let's talk about sleep deprivation, and then I'll let you guys go to lunch. All right, sleep deprivation. So we talked about sleep is important. It's imperative. We need to have it. It's when our body readjusts itself. It reboots. Deprivation involves decrease in the amount, quality, and consistency of sleep. Wait, deprivation involves decreases. Okay. When sleep is interrupted or fragmented, changes in the normal sequence of sleep stages occur, and cycle cannot be completed. You guys just want to finish it?
Yeah.
Yeah, let's just finish it.
Finish it, just go finish it.
Yeah, I don't want to come back and talk about
Can we
foot
still
things.
come back at 110?
Yeah, that's fine. All right. Physiologic signs and symptoms of sleep deprivation. You guys have to know these. Okay, be aware of these. Okay. Hand tremors. Patient's hand starts shaking a little bit. Okay. I'm talking not like when you guys do this. When we do this, most of our hands are a little uneasy. I'm talking about the patients right here, and they're like this.
So this is when you're sleeping.
Okay, sleep deprivation. You haven't had enough sleep, okay? This is what happens. Hand tremors, decreased reflexes, slowed response time, reduction in word memory, decrease in reasoning and judgment, and then cardiac dysrhythmias as well. Now, they did an experiment on this, and it's funny because that whole reduction in word memory is true. I saw it. The guy was, they did a 3-day experiment, and the guy was just messing up by the second day. Horribly. I'm like, he's got to be faking it, but it was for real. Mood swings, disorientation, irritability, decreased motivation, fatigue, sleepiness, hyperexcitability. Do these signs and symptoms, guys, describe of an are these descriptions of a good nurse? No, so it's important you guys get your rest, okay? Make sure you get your, and even when you guys come in here, make sure you guys get your rest, okay? Any questions on the signs and symptoms? No? Okay. If you guys don't sleep well, it'll shorten your lifespan as well, by the way. Promoting rest and sleep. You want to determine the patient's usual rest and sleep patterns, decide whether they are sufficient, and note why the patient is not getting sufficient rest. This can all tie into a nursing diagnosis as well. A plan should be developed to provide for more rest, limit the interruptions during the night. How can we limit the interruptions?
Try not to make it work.
Sometimes, guys, if a patient's alert oriented and they don't, we could put them in a room by themselves. Not like a private room, but like, you know, sometimes the census is low. We can just have A is vacant, but B, we'll throw them in there, close the door. We do that sometimes at the hospitals. You just come and check on them every once in a while. Okay. So we want to limit interruptions during the night. Also, we want to dim the lights, decrease. Night shift nurses, guys, we're the rowdiest. We put the TV on, the music on. We try. You turn it off?
Yeah.
You're a good nurse. We're bad. Not
the soothing music.
at big hospitals, guys, it's wild out there. Okay. You want to provide a quiet environment with a comfortable room temperature. What's a comfortable room temperature?
Not like
Not like this. This is not comfortable.
It's comfortable for me. It's very comfortable. Like in the 70s, guys. Like usually 74, 75 is pretty decent. It's 68 in here. Sorry. Limit the number of visitors and duration of visits. Carry out all procedures within a given time frame. Let's talk about preparing the patient for sleep. Wash the patient's back. Understand these guys, okay? Like the same thing that you would do to your kid before you put him to sleep to promote relaxation, the same thing you're going to do to patients. Wash the patient's back, gently massage the back, change the linens, make certain patients, make sure that certain patient is warm enough, or make certain the patient is warm enough. Offer a caffeine-free beverage such as milk. Highlight that. Please know that. Okay, caffeine-free beverage such as milk. Change salt dressings. Have the patient void. Environmental stimuli should be decreased by dimming lights and decreasing the noise level. Any questions? All right, come back at 1:05. It's 12:55 right now. I'm giving you guys an hour and 10 minutes.
11:50.
Oh, 11:55. Yeah, come back at just put it there. Yeah, actually, you guys can put all your phones right here, your recording devices. I'll just hang on to this. You have a recorder. Your brain. All right, folks. So take out some writing and some paper and pencil so you guys can write down. I feel like I'm at a news conference. Like we've identified the body. All right, you guys ready?
Yes.
Take a nap. I could wake up when you're done. Just teasing. All right, so I talked about pain scales, right? Pain scales. At what level can the patient actually function effectively?
4.
After 4, what do? We have to administer some type of medication or some type of way to diminishing that pain, right? Okay, good. When it comes to relieving pain, guys, how many methods are we going to use? Several. Okay, is there a limit? Like we can only use 2, we can only use 4? No, we use several different types of methods. It could be guided imagery. It could be visual stimuli. It could be auditory. It could be back massage. It could be medication. Okay, all those different venues work. All those different approaches work. Okay. What can unrelieved pain cause? Depression, anxiety, failure to thrive, bradycardia. You guys remember bradycardia?
Yes.
Okay, prolonged pain, bradycardia. How about acute pain, sudden onset of pain? You got decked in the head. Tachycardia, acute pain, right? But then, after a while, your orbit's fractured. It's been like that for 6 hours. What happens to your heart rate? It goes down. Okay. Okay. I talked about the TENS unit, right? Have you guys read up on the TENS unit yet? What would be a contraindication for a TENS unit? Pacemaker. Thank you for reading. Yes. Let's see. How does a TENS unit work? What theory? It's distracted stimuli is a layman's term, that's right, but it's the gateway theory. It actually blocks off that nerve impulse, right? Okay. Let's see. Give me an example of decreasing environmental stimuli. Turn off the lights. Okay, that's right. Soothing music. No music. She's talking about really turn off the lights. Okay, but yeah, you want to minimize noise volume. You want to minimize visual disturbances, things like that. Good. What happens if initially any type of relaxation technique that you try to implement doesn't work? What do? You try again. Okay. Bless you. What's another term for long term? Chronic, right? What's the best medication route to give a patient that has chronic pain? Oral. Okay, we read about that yesterday. Okay, read up on it again. Okay, for chronic pain or long-term pain care, it's oral. Okay, how about sudden acute pain, severe IV, right? Okay. Anytime you have a severe pain, what type of medication can you give? Are we going to give Tylenol?
No.
Are we going to give opioids, right? Okay, what's the strongest one that we usually talk about? Morphine. Good. Okay, let's see. What are the advantages of having the patient do like guided imagery and biofeedback and all that stuff? What are the advantages?
They can distract their pain.
Okay, but what are the advantages? Like, if you guys are dependent on me to give you a pain medication, you don't have that autonomy, right? But if you're thinking about, if you can actually think about something pleasant and get rid of the pain, or imagine something, that you have more control over that particular pain. No, what I'm saying is the advantages is that you have control over it. You have a control over when you do the guided imagery. Theoretically speaking, does it really help? Sometimes. Most of the time. Okay.
So this is for the patient that does the medication itself.
No, what I'm saying is understand this concept. If we have guided imagery, if we have biofeedback, if we have listening, relaxation techniques, the whole advantage of that is that you don't have to, you the patient, you don't have to wait on the nurse to do it for you. Meaning you can do it yourself. So that's the advantage. Okay, that you have control over that. You can take a deep breath and try to meditate. Okay, meditating works, by the way. No,
What are the disadvantages?
no, I want you guys to understand the concept. There is no answer here. It's just understand the concept, please. All right, I'm gonna move on now.
PCA, would that be under that too?
Yeah, PCA is there too. Another advantage of a PCA, the most advantage of it is that we have more control over it. That's right. What's it called if I have a clot in my femoral or inguinal area, but I have sharp pain in my foot, in my left and my right toe? Or forward pain, okay. What do you have to look out for before administering any opioids? Respiratory rate. What can morphine depress? Respiratory rate. What's the respiratory center of your body? The medulla oblongata. Yes. Okay. Anytime you're going to have a patient and let's say they're in chronic pain and you're going to do some ambulation with them, how early before you do the actual exercise do you give them medication?
30 minutes.
30 minutes. Okay. How about nausea medication? Same thing. 30 minutes. 30 minutes. Epidurals. Okay, epidurals. What are epidurals? They're nerve blocks, right? Usually given in the spinal column. And what do you have to look out for when giving respiratory depression? Okay, what else? Urinary retention. What else? Constipation. Okay. Hypotension, folks. It was specific to the epidural. Hypotension. If you have a medication due at 12 o'clock, pain medication, why is it important to give it at 12 o'clock or really close to 12 o'clock? Is that that's more of a better answer, sorry. Not so much the schedule, is because you want to make sure that the threshold of pain, it doesn't go above that, meaning that you don't have that breakthrough pain, to control the patient's pain. It can cause setbacks. Okay, if you have a lot of pain, you're not going to want to eat that much, you're not going to want to move around that much, so that's a whole concept that I want you guys to understand. Acute pain serves as a what? Warning sign. Which one does not? Chronic pain, right? Okay. If I tell you that every time I breathe, I feel something in my throat, is that objective or subjective data? Okay. If you see me sweating, what does that mean? That's subjective, right? Please know your objectives and subjective data, okay? When it comes to the sleep cycles, which sleep cycle would you have the least amount of recovery time when it comes to resting? Non-REM or REM?
Non-REM.
Which one would you have the least amount of recovery time? REM, right? Because in REM is when your eyes are moving rapidly. This is when you're dreaming, right? So if you're dreaming vividly, you don't have that deep sleep. Okay? Does that make sense? If you say that, man, I feel really tired. I slept 8 hours, but I feel really tired. You're gonna ask the patient, well, have you been having a lot of dreams? And if they say yeah, that's usually what they're gonna say, yeah, because they've been in REM cycle for the whole night, not the NREM, the deep sleep. Does that make sense? Okay, REM, rapid eye movement, is when you're dreaming. If you're dreaming, right, you're not having that deep sleep, that restorative sleep, that the NREM, the non-rapid eye movement stage. So if you're complaining about being tired and you had a lot of dreams last night, it's because you're in that REM state. You haven't been having that non-REM, which is when you're having that deep sleep. Okay? You want to talk to them real quick, or? Just give it to me. I'll pass it out.
That's what it is. There you go. That top one is yours.
Okay.
If you need it. If you don't, we don't.
Okay.
But I did include you on the email, so.
Okay, cool.
Yes.
I have a question
Sure.
regarding the CNA
Yes.
certification.
Yes.
Where can we get
Um,
the paperwork so we can go take the CNA?
Email Maria. You guys know who Maria is? Maria P.
Maria P. at success.edu.
Maria P. at success.edu. What'll happen is you'll have to pick up an application, and by you requesting the paperwork, you're requesting transcripts, and then she has to write up a letter for you.
Okay.
Okay, and then the application has all the directions on what to do.
Okay, thank you.
Okay?
Miss Lynn,
Yes.
actually, we need the schedule for the clinic.
I have him right here.
Because
That's why I'm here.
I have him right here. I have him right here, guys.
Any other questions? Thank you.
Thank you, Stella.
Yes. No. You're on one of these lists.
Thank you.
You're welcome. You're welcome.
All right. All right, folks, let's finish up. Let's see. I talked a little bit about post-op patients, and I gave some of you guys some incorrect information. I said that when you have a post-op patient, you usually give the medication around the clock, right? I went back and looked at the book, and I called my colleague, and actually you give them PRN only when the patient actually requests the medication. Okay? PRN, yeah. PRN only when the patient requests the medication. No, it's not going to be. Round the clock would mean, like I said, explained earlier, that it's every 2 hours, so you would always give it. But it goes against that whole concept that I was teaching, that if the patient has pain, we treat. Right? If the patient has relative pain past 4, we treat. If the patient's feeling great, we're not going to treat. Okay? Up until it gets to that 4th level. Okay? So that's why we give PRN as needed when the patient actually requests it. Okay? We don't want to over medicate the patient, because if we give too many opioids, what's going to happen? Constipation, bradycardia, hypotension, things like that. If you give a patient a back rub or a foot massage, what theory is that? Gateway theory. Let's see. So again, know the advantages of PCA, know what opioids can do as side effects. What culture is known to be a little more reluctant to admit pain? Latino. I like that. Latino men. Yeah. Or the we're close to the South, so Mexican American. I mean, we're all Mexican. I mean, you know, that's the stereotype. So yeah, Hispanic males, okay, typically, theoretically speaking, we don't like to show pain. Me, I show pain all the time. Like, I'm in pain.
you don't like to show emotional.
I show all of it. Baby, please don't go. Okay, let's see. No definitions, theoretically speaking, of acute versus chronic pain. How do you know a patient's pain has been relieved?
Smiling.
Okay, you're onto something. How do you know?
Body language, face expression.
What if they tell you, hey, I'm no longer in pain? If they verbalize it to you, okay? What if you have a patient that comes in, and again, like I said yesterday, they're smiling, but they say, my pain's 10. What do? Give them medications. You give them medications either way. No, because the whole concept is, what if they really are in pain? Or what if like something happens, and they're in so much pain that they have like an aneurysm? Who's liable? Because we don't follow the protocol. That's why you allow the physician to do what he will with that. But when it comes to nursing, the whole ethics behind it and the whole concept is we always treat pain as if they're feeling what they're feeling is true. Okay, mind you, when you're on that's theory. But I always teach theory, and then you have the real world. Are there nurses that just give saline instead? Yeah. Okay, there are. And that's okay, because that's what we had the placebo for. But if for whatever reason you give it to the wrong patient, then you're in trouble. Yes.
Example when they're in labor.
Except when, yeah, no.
Example when they're in labor, they don't complain.
Mhm.
They're all okay, and then they examine their labor.
That's what I was, yeah, like I said, my wife, she wasn't complaining, but she was dilated 8 centimeters. Yes.
Yeah, what if they're becoming like a safety dependent, they give them and they ask when they're pain?
Yes, it's not our job to distinguish whether they have drug-seeking behavior or not. We medicate either way. Mind you, according to the parameters that the doctor set. If it's every 3 hours and the patient wants it an hour and a half later, you have to explain that, look, I can only give it every 3 hours. If they keep telling you I have a lot of pain, you call the doctor and ask them for some breakthrough medication, like a bolus of something, like they can give for the time being. And you always want to assess blood pressure, folks. Always assess BP before giving the medications. If their PP is below 100, you don't give it, because they might become hypotensive. Bottom out. Please know what the TENS unit is, guys. Okay. What does independent mean?
To step on their own.
Yeah, to do things you're relying on yourself, right? Okay, dependent means relying on someone else. Okay. What does a cognitive mean? Thinking, right? Thinking. That's good. So if I talk about cognitive behavioral therapy, what am I referring to? What? Guided imagery, something to do with the patient thinking of something else than the pain. Okay. What is the pain threshold? What's the definition of pain threshold? That's the number of pain or the pain scale that a patient can no longer tolerate the pain. Okay, that's a threshold. Like I can tolerate any more of this. That's a threshold. What do you assess for when you're assessing pain? Okay, I don't know if I talked about this, but you want to do the PQRST method. I spoke about it last term. You guys remember the PQRST? So P stands for what provokes it, or what makes it palliative, or better, right? What relieves the pain. PQ stands for quality. Okay, PQR is radiation, region, PQRS. S stands for severity. Okay. Time. Okay. So this is the PQRST2. I spoke about it last term, but it's one of those things that will help you decide, or will help you in gathering information about the patient's pain. Yes.
When we do the assessment for patients, we often ask them what relieves the pain or
That's right. That's what provokes, or palliative, meaning what makes it better. Yeah, that's this part right here. If a patient has been in chronic pain, let's say, it's mild to moderate pain, and you notice that they start vomiting a little bit of blood. First of all, what's it called? What type of emesis? Hematoemesis, okay, meaning blood in your vomit. What type of medications do you anticipate this patient was overusing? Okay, what type of blood thinners? Aspirin or Nsaids. The Nsaids. Remember I talked about the Nsaids irritate the stomach? Okay. Okay, but yeah, aspirin as well though. What's Narcan? It's in your packet that I handed out today. Okay, so know what that is. We're moving on. Know what that is. We're moving on. Know your different types of pain scales, okay, guys? Know your different types of pain scales. Which one are you going to do for a patient who Little Miss Guadalupe that doesn't speak English? Okay. No, remember, cultures, different cultures. My grandma, she like that big. Not really. She like that big. Okay, so she's average size, right? But anyway, if she's in pain, she just looks pissed off. But she's not like, oh my God. But if you tell her, if you tell her something that's pleasant, she goes, oh, mijito, yes, and she shows you her 2 teeth and everything, but she's in severe pain. So you can't really go based on the face scale. So find out. Okay? In your book, it talks about it. Okay? How do you treat chronic pain? Round the clock or PRN? Chronic pain. Round the clock. There you go. What's the what does K stand for? What electrolyte does it stand for? Okay. What's the normal lab value of potassium?
3.5 to 5.1.
Okay. What happens if they're altered, whether it's too high or too low? Hypokalemia. It could actually mess with the electrical conduction of the heart, right? Okay, good. What is the average hemoglobin? No, hemoglobin, 12 to 16. Okay, now, if a patient's hemoglobin is 7, what's happening? They need a blood transfusion, right? They're bleeding out a lot. What if their hemoglobin is, let's say, 11.5? Okay. Well, remember, the average is between 12 and 16. Any females in here have any type of anemia? Iron deficiency anemia? Relatively, when you guys go check your blood, what's your hemoglobin? Do you guys remember? Is it 9? Is it 10? Or is it in the 11s? Usually 10s or 11s, right? Are you guys feeling like, oh my God, I'm going to die?
No.
No, but those are signs of anemia. Some type of anemia. You have less than what you need, right? Okay, good. What's the normal WBC count? 4,500 to 11,000. What happens if my WBCs are 18,000? What happens if they're 2,200? Immunocompromised. Yeah. Okay. All right, guys, go. Oh, wait, don't go home yet. All right, come up here one at a time when I call your names. Miss Monica Ramirez, Miss Sylvia Brewer, Miss Jessica Salaya, Miss Alicia Gonzalez. Oh, wait, that one's mine. I'm sorry. I'm sorry. Go. Come on, man.
Jason.